Hello, my dear students, and welcome. Chalo, today we are starting chapter 25 and we are tackling a topic you will see every single day in your clinical postings, skeletal muscle relaxants. Now, understanding these drugs isn't just about passing your exams. It's absolutely fundamental for patient safety in the OT and ICU. So let's get right into it.
So let's start with a very basic question that really gets to the heart of the matter. Why would we ever want to intentionally paralyze a patient, even for a little while? I mean, it sounds quite drastic, doesn't it? But just think about it. Imagine a surgeon performing a delicate operation where even the tiniest muscle twitch could be a disaster. Or think about when we need to put a breathing tube in to secure someone's airway. In those situations, these drugs become absolutely essential tools. All right, so here is our game plan for today. We'll start with why we need these drugs in the first place. Then we'll explore the two main ways to cause paralysis. Fascinating stuff. We'll see how we monitor it, meet the key drugs you need to know, and finally, we'll wrap it all up with a little cheat sheet of everything you must remember for your exams. Okay, let's jump into section 1, the why. What are the critical clinical situations that demand we use these very powerful drugs?
Here's the most important thing I want you to remember. These drugs are adjuvants, okay? They are helpers to general anesthesia. They don't make the patient unconscious and they don't block pain. Their only job, their one and only job, is to create a still, relaxed surgical field. And that, my friends, is absolutely critical for the safety and success of so many procedures you're going to see.
Now, this is where it gets really interesting from a pharmacology point of view. You see, we don't just have one way to do this. There are two completely different mechanisms, two different paths to get to the same destination, both targeting the neuromuscular junction. Let's look at them side by side. Okay, everyone, I need your full attention on this table. This is the absolute core of the chapter. On the left, we have competitive blockers. Think of them as simple, competitors. They just sit on the acetylcholine receptor and block it. Simple. This leads straight to a smooth, flaccid paralysis. Now look at the right, the depolarizing blockers, like succinylcholine. These are agonists, so what do? They first activate the receptor, which causes those little initial muscle twitches you see. We call them fasciculations. It's only after this initial kick that they cause paralysis by keeping the receptor stuck. And this one difference explains everything else in this table. Look at neostigmine. It reverses the competitive block, but it does nothing for the depolarizing one. This is a classic Viva question, so make sure you understand why.
Now for a concept that is a little bit tricky but very high yield for your exams. Phase 2 block. You see, if you give a depolarizing drug like succinylcholine for too long or in very high doses, something strange happens. The receptor, it basically gets tired. It becomes desensitized. And what's the result? The block starts to look and act just like a competitive block. You'll start to see fade when you monitor it, which we'll talk about next. So please grasp this concept. It's very important.
So if a patient is completely paralyzed, how do we actually measure the block? We can't just guess, right? We need a reliable, objective method, especially when we want to know if it's safe for them to start breathing on their own again. And this brings us to monitoring. Okay, look very closely at this diagram. This is the train of 4, or TOF, and it's our main tool for monitoring. We use a nerve stimulator, usually over the ulnar nerve at the wrist, and we give 4 quick electrical pulses. See the middle example? That's a competitive blocker. Notice how each thumb twitch is weaker than the one before it. T1 is strong, T2 is weaker, T3 weaker still. That progressive weakness is what we call fade. Now compare that to the example on the right. With a depolarizing block, all 4 twitches are reduced, yes, but they're reduced equally. There is no fade. This simple visual pattern is incredibly powerful. It tells us exactly what kind of block we're dealing with.
We can actually put a number on this fade by calculating the TOF ratio. It is very simple. It's just the strength of the 4th twitch divided by the strength of the first one. So when a patient is recovering from the paralysis, we watch this ratio very, very closely. As it climbs back up towards 0.9, that tells us that muscle function is returning, and they're getting strong enough to protect their airway and to breathe on their own.
Okay, with the theory covered, let's now meet the main players. These are the specific drugs you will see being used every single day in the operating theater.
First up, succinylcholine. You can think of it as the sprinter. For speed, there's no competition. It works in less than 90 seconds, which is why it's the go-to drug for emergency intubations. But, and this is a huge but, it has a very dangerous dark side. Remember how it depolarizes the muscle cell? Well, that action forces potassium to leak out of the cell.
In a healthy person, it's a tiny rise, no problem. But in a patient with major burns or a crush injury where the muscle cells are already damaged, this potassium leak can be massive, and it can cause a fatal cardiac arrest. You must remember this contraindication.
Next is vecuronium. This is a true workhorse in the OT for all your routine surgeries. Its biggest advantage is that it's incredibly stable and predictable. It doesn't cause crazy swings in heart rate or blood pressure, which makes it a very safe and reliable choice for keeping a patient paralyzed during a procedure.
Now we have rocuronium, which is very popular these days. You can almost think of it as giving you the best of both worlds. At the right dose, it can be almost as fast as succinylcholine, so it's great for rapid intubations. But because it's a competitive blocker, it completely avoids those dangerous risks like hyperkalemia. This versatility makes it extremely useful.
Okay, now for a really unique mechanism you need to know for your exams. Atracurium and its relative, cisatracurium, have a very special property. They break down spontaneously right there on the bloodstream through a chemical process called Hofmann elimination. So what's the big deal? Well, this means their metabolism is completely independent of the liver and the kidneys. This makes them the absolute perfect choice for patients who have severe organ failure.
Okay, let's take a quick moment to clear up a very common point of confusion. There's another group of drugs that are also called muscle relaxants, but they work in a completely different universe from everything we have just discussed.
This diagram shows it perfectly. See, drugs like diazepam or baclofen, they don't act at the neuromuscular junction at all. Their target is the central nervous system, the brain and the spinal cord. They work by dampening the signals that cause muscle spasticity and tone.
So here is the bottom line. And please do not confuse these two in your Viva. Centrally acting relaxants reduce muscle tone and are used orally for chronic conditions like spasticity. Neuromuscular blockers cause complete paralysis and are given IV for acute procedures like surgery. One works on the brain, the other works directly on the muscle. Two totally different jobs.
All right, everyone, we are almost at the finish line. This next slide is your clinical cheat sheet. If you are studying last minute for an exam, these are the absolute must-know points.
Let's quickly run through the high-yield facts. 1. Know the two main types, depolarizing and competitive. 2. Remember the key risk of succinylcholine is that life-threatening hyperkalemia. 3. Understand train of form monitoring and that concept of fade. 4. Appreciate the stability of newer drugs like rocuronium. 5. Remember atracurium's special metabolism for your patients with organ failure. And finally, never, ever confuse central with peripheral agents. Master these points and you will be in fantastic shape.
And to wrap up, I'll leave you with a clinical scenario to think about. You have a patient with 40% body surface area burns who needs an emergency intubation. Based on everything we've just discussed, which muscle relaxant is absolutely contraindicated and what is the precise mechanism of that danger? Think it over. Thank you for your attention.